Hello, my name is Valerie Delpech and I'm a medical epidemiologist and head of the National Surveillance Unit of HIV infections at Public Health England, based in London. This lecture consists of two parts and will provide you with an understanding of and the steps taken in measuring the continuum of care for people living with HIV. Now, the term continuum of HIV care is also referred to as cascade of care, and it refers to the presentation of public health and other data in a sequential manner to illustrate the public health impact of HIV testing interventions and the clinical management of people living with HIV infection. The overall public health impact is the measure of the viral load suppression at the population level. This method of presenting country or regional level data to assess the quality of HIV testing and clinical care has become popular in recent years, following evidence that antiretroviral therapy is effective in preventing onward transmission of HIV. There are variations to the continuum of care, but essentially it consists of a series of data columns and pillars. In this lecture, we describe the cascade beginning with the estimated number of people living with HIV infection through to the far right, showing the proportion of all people living with HIV who are virally suppressed. The main objective of the model of the HIV cascade is thus to identify and quantify the total number of persons living with HIV in a given geography and illustrate the losses in engaging and retaining people along the continuum of care. We are now going to look at the continuum of care in more detail. In this figure presented here, we see that the first bar shows the number of people estimated to be living with HIV. The second bar, the number and proportion of people living with diagnosed HIV who've ever been tested and are still alive. The third bar represents the number and proportion of people living with HIV currently enrolled into care, while the fourth bar, the number and proportion of people living with HIV currently on treatment, and the last bar, the number and proportion of people living with HIV on treatment who are virally suppressed. This example shows that of the estimated number of people living with HIV, 60% has been diagnosed, only 50% of those who have been diagnosed have been enrolled in care, and of only 45% are currently on treatment. Finally, 65% of those on HIV treatment are virally suppressed. Thus, of the total number of people living with HIV in this country, which in this example is 8,000, less than 9% are virally suppressed. The treatment cascade can be presented in several ways, and in practice that depends on the available data. Another example of the treatment cascade, this time from Estonia, shows a high proportion of people virally suppressed, although still low, and also includes the indicator retained in care. This is from 1 year to the next. An example from France here shows that 56% of people living with HIV in France nationally have suppressed viral load. The continuum of care cascade is, as we now see, an effective visual instrument to identify and monitor the successes and challenges of the healthcare system. It can be constructed using national level data to offer a snapshot or cross-sectional overview of the situation for national program managers and partners, but it can also be drawn from data on regional, district level or clinical data. It is also very relevant to look at key population groups separately, such as, for example, men who have sex with men, women and girls, or migrant populations. By looking at these separately, we can see where gaps of the continuum of care and programs may fail, and how to better engage and retain these key populations living with HIV. We are now going to discuss the national cross-sectional cascade. This graph attempts to show the overall national picture for a given year. The first bar is the estimated number of people living with HIV, which we will discuss in the lecture later. The second bar shows the number of people living with diagnosed HIV who are currently alive. This is usually derived from the total number of people in a national HIV case registry minus the number of people who have known to have died, if these data are available. the denominator in the total number of the estimated people living with HIV, and for the enrolment into care indicator, the definition currently varies from country to country and are often dependent on the available data. Ever enrolled in care may refer to people living with HIV who have been assessed at least once for HIV care and treatment, including, for instance, those who have received at least a CD4 count, or those who've been seen at least once on treatment by a treatment prescriber, or there may be a third nationally agreed definition when a patient is considered enrolled in care. This will vary from country to country. The fourth bar, showing the number of people living with HIV on treatment, can usually be derived from other treatment site records or registers. Sometimes this is presented as the current number of people on treatment, sometimes as a cumulative number as ever started on treatment. This will depend again from country to country. Viral load suppression is generally defined as less than 200 copies per mil, but this also is not universally agreed, and therefore you will see different definitions shown in different cascades. These data are usually available from patient records or registers and should be for people who have been at least on treatment 12 months. The denominator for this indicator will then be the number of people on treatment who have a viral load measurement in the past 12 months. It may also be relevant to draw up a HIV treatment cascade for a specific facility. This may present a snapshot look at one clinic or hospital and will then include the steps from enrolment in care to viral suppression as shown in this figure. HIV treatment cascades at the facility level may also be a cohort-based cascade, which follows a specific group of people living with HIV, for example, from one clinic or hospital from the time of their diagnosis through to the last point in their service delivery. The treatment cascade can reveal gaps and loss to follow-up of patients, as well as provide some guidance and reveal inequalities in healthcare delivery. This will help ensure that all people who attend the clinic or hospital are treated optimally. Despite the use of the continuum of care, there are several limitations. First of all, there are no standard definitions, making comparisons between countries quite difficult at the moment. Secondly, some of the relevant data may not always be available or representative of the total population being considered, and this may skew the results. An example of this, sometimes only cumulative data on enrolment in care are available, and data from death registry may not be reliable. Therefore, not all countries have sustained viral load measurements for all patients on ART, and not all countries are monitoring systems set up to directly measure the number of people living with HIV who have been diagnosed. Separation of public health and clinical data may result in double counting, delays in registration, or inaccuracies in the number of patients in care or at a given point. Thirdly, it is important to accurately identify the number of deaths and those persons lost to follow-up, and this is sometimes not available. It is important that the time frame of the different data sources are also available and equivalent. For example, if the estimated number of people living with HIV as of December 2015 is the desired time, then the number of diagnoses, enrolment in care, on treatment and suppressed viral load should also be December 2015. This is not always possible as data collection item varies, and this will in fact affect the final cascade result. Finally, changes of integrating time elements into the continuum of care have also been described. For example, time elapsed between diagnosis and enrolment in care. Such time elements are currently not possible to assess from the cascade. This is the end of part 1. We will begin part 2 by discussing target setting for the treatment cascade.